I'm really proud to be in an audience with people with very big brains, but more importantly with big hearts, because I think this is a journey of the heart that we're embarking on. And what I'm going to talk to you about in 4.5 minutes, we've had instructions, is our journey around improvement of data and our interpretation of data. So, people in this room might get a heart sink when they look at this because it's a Daytix form. But our journey to date has been around needing to make some very important changes to our incident reporting system. Because before February, we weren't easily able to extract the information that we needed to be able to assess our progress in terms of our measurements around restrictive practice. We weren't also able to respond properly to government requests for information around levels of prone restraint, for example. So for people in the room who don't know about Daytix, it's the Trust's incident reporting system. It's where people can report incidents at team level, and it's usually done by frontline staff. So in the context of positive and proactive care and restrictive practice, we needed Daytix to provide us information to assess our progress. We needed meaningful information to respond to requests by the NHS benchmarking, so as we could assess how we were in terms of other trusts. And we also wanted to be able to provide wards with information that was meaningful to them as well around their own practice, because Denise talked earlier about the governance processes that we have in the Trust, that these sorts of issues need to be discussed at every level within the organisation. So in terms of the changes that we've needed to make, and I want to formally thank Hertfordshire Partnership Trust because they'd already embarked a little bit on this journey before us. But we were in a situation prior to February where we were potentially underreporting our incidents because our Daytix system was set up that the restrictive practice drop-down menu would only come up in certain circumstances where an incident had been categorised as either behavioural or violence types of issues. So issues to do with service user self-harm, medication issues or security issues weren't pulling up the menu for then staff to be able to choose. We had to rename a section to make it clear about what staff needed to report on. And we needed to list also the full range of physical interventions on which the Trust training is based on. And that helps us to see whether or not the techniques that are being used in instances of restraint are actually the ones that are being taught by Stephen's team. Stephen will be speaking next. We also needed to add some additional fields to promote this whole notion of debriefing, the real fundamental importance of debriefing, and also to give an opportunity for people to think there and then, how could this have been avoided? So what we're effectively doing is building in improvement systems, reflective systems within some of the mechanisms and systems that people are using every day. So this is where we're now at. So in February, we wouldn't have been able to show you information like this. But we were able to see at a trust-wide level our number of physical intervention incidents. Of those, how many are related to what we would call full restraint and broken down to prone restraint. So that's what we get every month to our positive and proactive care group that scrutinises this data and assures its accuracy. And that group has a range of ward managers on it as well as senior trust staff. We can see a breakdown of where those incidents may have taken place and the sorts of techniques were used. And at an individual ward, we have ward dashboards too, where we're beginning to populate those with meaningful information about restrictive practice, So last month we were able to show the number of prone restraints ward by ward, which are very, very few. We've only had 4 in August, and I think 4 again in September. But this will be an iterative process, so next month we'll be able to report on a range of other physical interventions too. So you can see we've come on quite a fast journey really in the last 4 or 5 months. So in terms of our learning through this process, Daytix is a system that is clunky, that staff don't like. The form seems to be growing and growing. And staff need training. I think we heard from Hertfordshire that sometimes the wrong box is ticked. So the quality of the data obviously is not robust. So we're focusing our improvements on better completeness of the Daytix forms and doing some work around definitions. So for example, some staff on our older people's wards, when you talked about restraint, didn't appreciate that a safe hold was a restraint, for example. So there's some education needed around definitions. We've taken a very incremental approach to how we look at our data. So in terms of our prone restraints, we can now be fully assured that that data is accurate. And we want to do the same around our range of other physical interventions. The data helps us to proactively support teams, and we're now looking at debriefing, and we're starting to pilot a systematic approach to debriefing. So that's it.